when it comes to the finding the dermatomes, so what are we talking about here? Motor cessation and DTRs, right? So you guys went through the exercise, you figured stuff out, you worked as a team, took some interesting pictures, right? I like how people protected faces in case it was a full body shot, so that way they could protect the innocent from the guilty. And I look forward to printing them out and putting them on my refrigerator.
Won't be the first.
It won't be the first, just put it right next to it, the other ones, right? But the whole exercise was to get you thinking and just to familiarize yourself again in case you didn't hit it a little bit more than, well, as hard as you would like to have in Clint's skills, right? So everybody likes to have an answer, right? What are the answers? What am I supposed to know? What am I supposed to be studying? Here's the answer, okay? If you look on my page under the videos, this guide is there, okay? So if you look at this guide, it tells you the nerve roots and the distributions as far as motor, sensation, and also DTRs, okay? So that's upper and lower extremity, correct? So if you look at that, that's the answer, quote unquote. Okay, so why do I bring this up now? Spend a few minutes talking about it. We're not going to quite get into the spine stuff today, the neuro stuff, but I want you guys to start familiarizing yourself because I cut out there. Still cut out? I'm back. You guys hear me? Yeah, if you if you look at what I told you, right? I told you if you get a question on the test and you get a vignette or a stem and you get the motor and the sensation part or the motor and the DTR part, what's left? You have to figure out what that third component of it is. Make sense? So if you're given a distribution, right, of a sensation, a dermatome, and you're given a reflex, then you have to tell me what the motor is. Pause. More answer. Always acknowledge people, especially if they outrank you. So if you don't get to that point where you understand that, then you're going to struggle. Okay? And again, I'm trying to set you up for success. I'm not trying to just set you up to take tests and pass them. Okay? So when you get to neuro, hopefully this will guide you as well. Make sense? So that's why I spent time on that. And it was not something that was supposed to be overly taxing. And you guys are worried about picking up points, missing points, stuff like that. Just activities to make sure that you hone in on that skill set that you should have at some point. Okay? I can tell you 100% you will have questions like that on PANTS. 100%. I just took, again, my review, and I took the research, and they asked me a question that was exactly how I'm teaching you guys. Okay? And so I was like, oh, I know what that is. I better know what that is. Good Lord, right? So, but they also asked me, like, nerves. If you're talking about their sensation, and it's diminished on this aspect of the forehead or the face, what nerve is that, right? And they were getting at the trigeminal nerve, right? So they asked me, like, it's not test compromise, but let's say, in my hypothetical world, they asked me, what nerve is that, right? So if I didn't know that answer, that meant that I didn't understand my neuro exam. That's what they're getting at. It's not just a straightforward question. You remember, your guys are getting tested also on history and physical taking, right? So that was the skill that they were testing, was my ability to take a physical exam finding and correlate that to a pathology, to a condition. Good to go? Everybody understand that? Okay. Do you guys want me to print these out for you guys? Because I know you got access to printers is scarce, right? Somebody told me you guys got booted from the printer at the library.
Yep.
Yeah, so I'll print that out for you. Somebody said yep, so I'll just go with yes.
Yes, please, thank you.
Yeah, copy. Okay, all right. Any questions about that? Okay, good. All right, so you guys are gonna get to know one thing about me, and one thing about orthopedics in general, is that we see infection everywhere. You tell me if there's redness, warmth anywhere, I'm gonna assume it's infection until otherwise proven, and it's not just inflammation, and it's not just RA, etc. Okay? So today we start talking about infection. Let's break down this word real quick. Osteo meaning bone, correct? Myel, right? M-Y-E-L, that is nerve, That is a root word, excuse me, that's supposed to denote bone marrow or spinal involvement. Okay, so in this case, we're talking about bone infection, correct? So, and that's infection that is not just necessarily superficial, it's in the bone marrow itself. You would agree that the bone marrow, in some way, shape, or form, can and will eventually communicate with the whole body, right? So if you have osteomyelitis that's focused on one area, so bone infection is focused on one area, and you're now having systemic symptoms, that could be an indication that this is getting worse, correct? Okay, so a lot of times we focus in on pain, and again, I don't want to be insensitive, but pain is only one thing, and it's not the measure of what we're trying to treat when it comes to infection, okay? And your job as primary care providers is to find infection wherever it lives, okay? Now that we've established ground rules for what it is, I should use my clicker, then we start talking about the etiology and expand a little bit more upon definition. In this case, when we start talking about osteomyelitis, I want you guys to start zeroing in on these slides where I put things in bold, gold, and red, right? Because the bold gold means that these are things that are commonly occurring, but also commonly tested and important to know, okay? So when it comes to pediatrics, and again, pediatrics underlined underneath it, etiology, what is the most common form of seeding for, or etiology, excuse me, for osteomyelitis? Blood, hematogenous, right? Came through the blood, okay? And the most common organism is what? Staph aureus, okay? So if you ever had a guess, right, when it comes to something that could be potentially skin related, either breaking the skin or some kind of seeding through the bloodstream, staph is everywhere, right? So 80-20, 50-50, right? So just kind of zero in on that. Second most common is group A beta hemolytic strep. So that is also a skin flora, correct? Okay, so again, start associating these patterns when you're studying. All right? Have you guys had infectious disease yet? No? Okay, that'll have some twisters, right? That'll have those weird ones. But when it comes to this, it's the common ones. Okay, so common things occur commonly. Not H flu, Haemophilus influenzae. So why do you think that it's not H flu anymore? Because it used to be. The most common used to be, right? Vaccinations. But what do you think is important to ascertain from a history then? Vaccination status. So if you call me and you give me a report on a patient, and you don't put that in your report, right, your little bullet, if you will, your quick synopsis, I'm going to ask you, what's their vaccination status? Okay, good to go? So this is showing a hip, correct? Invading infection there in the hip. So if you look at this distribution here, right, and you say, well, the femur is, the proximal femur, excuse me, is involved with the hip, correct? And what's the percentage there?
23 to 29.
23 to 29%, so a third, correct? About a third, upwards of a third. So it has a high likelihood to be. So if a patient comes in, a pediatric patient, do you think that if it's a pediatric patient, they're going to be 100% verbal and be able to tell you exactly what's going on? No, they're just going to say, don't touch me. It hurts when you touch my hip. It hurts when you move my hip. So hip pain in pediatric populations is something that we in orthopedics take very seriously. You tell me a pediatric patient is unable to ambulate, you're unable to do range of motion of the hip, what am I thinking? What's the word? Osteomyelitis or just infection. Make sense? So you're going to see a lot of kids that don't want to bear weight, and you're going to have to figure out what it is. And we'll talk about other conditions that it could be, so your differential diagnosis will continue to expand. Okay, enough about that slide. So adults, underline, underneath it, what is the most common spread there following certain events, right? So if they've had surgery, it's direct inoculation, right? If they have vertebral involvement, meaning the vertebrae, the spine, what is the most common? Hematogenous spread. Okay? If they have nasty diabetic feet or lower extremities, okay, you guys will get paranoid about diabetes too eventually, then you're thinking what? Contiguous spread, meaning that that infection that was superficial has now gone down to the bone. So what is an example of that, you ask? So you get somebody in clinic, they have a big nasty sore in their foot, they have low-grade fevers, they're reporting an increase in pain, right? You might look at that wound and explore a little bit. Use some saline, clean it up. You might take a cotton tip applicator, which you'll hear abbreviated, or just to be fancy, say CTA, cotton tip applicator, right? But the long ones, it's a stick about that long, right? And on the end of it's cotton. You'll take that stick and you'll stick it in, right? And you'll see if it probes the bone. If you're able to take that cotton tip applicator, the CTA, and go all the way down the bone, and you have those other symptoms, are you concerned about infection? The answer is yes. Okay, so I always try to correlate clinically whenever possible, and hopefully that example helps you. Okay, make sense? So what's the most common organism in adults? So nothing changed, correct? Just the transmission. Okay, so make sure that you don't confuse those. Read the entire scenario and try to discern what it is that the question is asking you. Okay, and how serious potentially that condition that they're describing to you is. Any questions about that? So I broke this up a little bit more. Apparently I can't go past there. So I broke this up a little bit more. Hopefully this helps you, because when it comes to osteomyelitis and the clinical symptoms, it can be a little challenging, again, depending on what age group you're talking about. Neonates typically are the most challenging, right? Because they, if you look at the bottom left there, they're just crying. Do babies cry? Yes. So you ask the parents, is this more than abnormal? They seem fussy, and then they just seem to want to not use that extremity. Okay? Again, it doesn't have to be a hip. I'm just telling you that very commonly it is, right? Up to a third of the patients are hips. Okay? Meaning proximal femur, correct? So pseudoparalysis, that's what that topic was, or that idea that was that I was describing to you, which is where they just don't seem to want to use that body part, that extremity, okay? So pseudo meaning it's not true paralysis, it's not something that's nerve related, it's just that they're self-limiting themselves. Does that make sense? So I tell you to focus in on that. Because again, neonates, at what point are they fully vaccinated, right? They're not fully vaccinated for a bit. There's a schedule, immunization schedule. Anybody here who was a kid knows that? You go in for regular immunizations. So again, that could be a little more challenging, okay? Pediatrics, going back to the top left there, vague symptoms, okay? Vague symptoms, meaning they just say, oh, my hip just hurts, and then they refuse to want to move it, and they refuse to want to let you examine them, right? But what's the usual age population in pediatrics that you'll see this in? Under 5, right? So basically you get the idea that neonates and up to 5 years old can be challenging to discern whether their clinical symptoms are indicating infection or whether their clinical symptoms are just something else. Okay? Adults, a little more straightforward, right? Top right there, fever. Okay, there you go. There's the fever. All right, everybody zeroes in on the fever. But decreased range of motion of adjacent joints. So meaning that not only do they not want to move their right hip, but now they don't want to move their left hip either. It just hurts to do any kind of movement in that area, or they don't want to bend at the knee as well as the hip, okay? So adults can be a little more straightforward. Can you get a better history from adults? 100%. And so it can be challenging again until you get to adults, so. Yes,
Is this saying that when you find a fever in pediatrics, it's only adults, or is that blanket for a neonate or pediatric with this as well? They all?
that's a good question. So his question was, will you always have fever in neonates or pediatrics? Or is it saying that adults will always have fever? As you guys know that when I teach you, or hopefully I teach you, not to think algorithmically. Does every single clinical presentation mimic any presentation you may see in a textbook? No. So neonates and pediatrics, you may have a quote-unquote low-grade fever and not have a fever, okay? So again, that's why it's challenging. So no, it doesn't denote that the fever is exclusive to adults. But usually with adults, again, adults, are we dirtier? I don't know. So, but, yeah, tend to declare themselves a little bit more, okay? Make sense? Again, getting back to that RA, for example, and I know I go back to RA, hopefully you understand that's important. But RA, does it spare the DIP joints? It does. No, it does. Okay, but no, it doesn't. So in 2.1% of cases, our patients with RA will have DIP involvement. But 2.1%, that's very low, correct? So as a whole, and for testing purposes especially, RA does spare the DIPs, okay? But that's an example, not to throw you guys off, but that's an example of why you can't think algorithmically in medicine. As soon as you do, you'll miss something. Okay? Good to go? So you may dismiss that low-grade fever in a neonate and say, kids get sick, right? But you gotta do a physical exam, and sometimes you have to do imaging, especially in neonates and pediatric patients. And adults as well, but I'm saying you have to have a high level of clinical suspicion. Did I answer your question? Yes, sir. Levi? Okay. All right, so previous open fractures of post-op patients, draining, wounds that just don't want to heal are infected until otherwise proven. That's basically the concept I want you guys to understand. So you get a good history, you realize this patient just had surgery 2 weeks ago, let's say total joints, God help you. We're so paranoid of infection in total joints because when you get an infection in a patient with a new hip, do you sometimes have to take all that hardware out? Yes, it's a big deal, so you gotta decide, okay? So again, not to get too much into any one thing, but if they're post-op, you should think infection and roll back and work backwards, okay? Especially if it has substantial delay in the healing of the wounds. Okay? Questions about that? All right, osteomyelitis, right, on physical exam, if you have a fever, what's the magic number there? 100.4, right, or higher. Tenderness over the affected bone. So again, you do a physical exam, you have focal tenderness. Everybody understands what I mean by focal, meaning it's specifically to that one area, that one joint. Okay, diffusion is common, especially later on. Okay, because if you have infection, do you have inflammation? Yes, right? But the question becomes, everybody understands that, in this case, it's osteomyelitis, right? So this is infection of the bone marrow. What if that infection goes from the bone marrow into the joint itself? Because it is proximal femur, correct? So if it goes from being at the proximal femur, and then works its way into the synovium of the hip joint, then you got a whole other set of issues, correct? Right? Because not only is it the bone itself, right, osteomyelitis, bone infection, but now you've got a hip joint infection as well. So you have to have a high level of clinical suspicion to decide whether or not it's solely isolated to a bone, right, bone marrow, or whether it has seeded out into, well, seeding is probably the wrong word, right, but it has violated, if you will, the joint capsule itself, and now you have full-on septic arthritis. Okay, is that worse? Yes. All right, so potentially. Okay. Decreased range of motion, right? So what do you mean by decreased? The reason it says but possible is that can you move the hip at all, or are they super guarded? Guarded meaning they don't want you to touch them. They don't want you to move that hip at all, right? Make sense? Okay. When somebody calls me from the ER and says, hey, I got a patient for you. Oh yeah, that's nice. Go ahead, just tell me about this patient. I got this kiddo, and he refuses to bear weight. Ding, right in my mind, I'm like, ooh, so he go up and stand on that at all. You can't get him out of bed to stand up at all. Oh, what I hear is challenge accepted, right? Because I need to go down there and make sure, is this just transient synovitis, which we'll talk about later, meaning it's just something that's going to pass, or is this like osteomyelitis plus or minus septic arthritis, okay? So again, the range of motion, if you just put it in your mind, oh, it's just always going to be decreased. Understand that decreased is a scale, right? Meaning they may move it a little bit, but if they won't move it at all, and they definitely won't bear weight, you should be more concerned. Good to go? Because physical exam is going to be big on this, especially in pediatrics. Antalgic gait is what I just described. Right, so you have refusal to bear weight on the affected extremity. For those ER guys out there, budding ERP guys, right, and gals, if you document refusal to bear weight and discharge somebody, and they bounce back and they have full-on septic arthritis, right? I trained civilians, so we used to say you're going to write a check on that one, right? Someone's going to sue because you missed it. Make sense? So never, ever, 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 ever document refusal to bear weight, and don't figure out if it's actually infection or whether or not this patient just had some other condition. Are we good there? Now you look at that picture there, that's a 3-year-old boy. Again, we said less than 5, right? Okay, 3-year-old boy, you see that swelling there? Okay, you look at that, you're like, that doesn't look good. Do 3-year-olds get hip pointer injuries? Are they football players? Crazy stuff like that? No, they don't get like hip strains and sprains and strains, okay? If they get swelling like this, you should think infection. Good to go? Okay, I'll make you paranoid eventually. All right, so laboratory studies. So laboratory studies, again, ESR, CRP, are those specific or sensitive? Oh, excuse me, yes, I said it correctly. Specific or sensitive for any one thing? No, but you're still going to get them, right? You're going to get all these labs, okay? And remember, this is osteomyelitis, okay? Don't confuse it with septic arthritis. This is in the bone marrow, okay? Are you going to tap an otherwise healthy joint? No, this is osteomyelitis. So if you're going to have to go in there and get some of it, as they say, as I say, you're going to have to go into the bone marrow and get it, or into the wound and get it, right? You're going to have to go in there and either do an open or aspiration of the affected area, hopefully not violating the joint capsule if it is in proximity to the joint capsule, because then you got a whole other set of problems. Good to go? So it has to be focused. Yes, sir.
So, sir, if we have an unstable patient,
Unstable, define.
we have
Hemodynamically unstable?
hemodynamically unstable.
Okay.
We are sending an unstable patient.
Hemodynamically unstable?
Are we waiting on culture, or are we just going to send empiric antibiotics if this is a
We'll talk about it here in a second. Okay? Why do you want to get that's a good question. So his question was, right, are you going to just treat, or are you going to wait, are you going to get an aspiration or a biopsy and then treat? Okay? If there's a question of the diagnosis and it's unclear, you're going to go ahead and do the study first, right? So get the culture or get the biopsy first, then you're going to treat. Because when you culture those things, when you take those samples, are you going to send that for analysis? Yes. So if it has been bathed in antibiotics, right, is it going to skew your analysis? That's why it says prior to antibiotics. Okay? Sick? If they're septic, you're going to treat. Because the diagnosis has declared itself, by definition, correct? You have made a diagnosis, correct? Okay, good. So that's what I'm saying. If the diagnosis is unclear, you can't delay. But if the diagnosis has been clarified, and again, we're only on the lab part. So maybe that question was going to make a little more sense in a few more slides. All right, this is only labs. This is just one part of the evaluation, correct? Okay. So if you get that histology, right, so that analysis of the actual sample that you took, they can differentiate acute versus chronic. Do adult patients, especially with diabetes, sometimes have chronic osteomyelitis? Yes. And your book talks about a little bit more. I'm not going to go that deep into the weeds, but just understand that the slides will look different. So what this picture is supposed to denote to you is that what it looks like when you have acute, right, versus chronic. Okay? Do you need to know that? Not necessarily. Okay? And not for the purposes of my test. All right? I cut some stuff out here because there's too much in the weeds. You guys are not budding pathologists. Unless you want to be. Okay? But serum-wise, and again, we're talking about serum, right? So blood, right? Take the blood, spin it down. White blood cell count, in this case, will usually be elevated. Blood cultures can help you, correct? When you're taking blood cultures, do those take time to come back? Those do. So if you're going to get blood cultures, again, you need to get them quickly or timely, and you need to not start antibiotics before you get the cultures. If you start antibiotics first and then do a cultures an hour or two later, is that going to skew the results potentially? Yes. So again, think about these things before you just execute. Okay? CRP is in bold gold. Why? You guys will get into later lectures, not in my course necessarily, but you understand that CRP is something that we use to trend for improvement or worsening of infection. That's what we're getting at there. Okay? ESR, again, not super helpful, but it leads to the bigger picture. But C-reactive protein, CRP, and again, the one that's related to not heart, right? If that's elevated, and then you're kind of watching the patient, you're starting antibiotics, and a day later this CRP doubles, is your treatment effective? No. So again, it can be used to trend for improvement or worsening of symptoms. So I urge you to get, even if you're just watching, right, make sure you get baseline labs so you can trend them and see for improvement or worsening of symptoms. Does that all make sense? Imaging-wise, again, this has very specific imaging. Focal osteopenia, so you see areas that the bone is not as dense, right? And then you see soft tissue swelling, periosteal elevation. Periosteum is what? It lines the bone, correct? Periosteal lining, okay? So you can see periosteal elevation in early osteomyelitis. You'll certainly see it later, but that may be the first indication you have something involving the bone. But all these things can be normal in early disease, okay? But it's important to really, really understand that the sooner you catch this, the better the prognosis, correct? Because then you don't have progression in septic arthritis, okay? You see that focal osteopenia there, and there, and there, okay? And again, for you guys on this side, there, and there, these two are supposed to correlate there, okay? So when you see that focal osteopenia, that's a pocket of infection, correct? That's something going on, right? So obviously you've got to the point where you get an MRI, but if there's a question about whether or not something is a tumor or it's infection, then the MRI with contrast can help differentiate that. Okay, makes sense? So if we're talking about infection, Major Davos, why, you're saying that there's fever. Can you have fever as a presenting symptom for cancer, for bone tumors? You can. You guys learn fevers, unexplained weight loss, right? Especially night fever, right?
Yes.
Unexplained weight loss, things like that. Night pain. Okay, so again, your differential is expanding every lecture period that we go through. I hope. If it isn't, let me know. So bone scan, right? So bone scan. So if you're going to scan the bones, right? You guys talk about bone scans, right? In radiology? Okay, so you understand what it's used for. If you just bone scan every patient out there, right? Do you think you're going to have areas that are going to glow? Especially in adult patients that are like, for example, infantry, right? Their hips are gonna glow, their ankles are gonna glow, everything's gonna glow, because they're just, bone scan will show uptake in areas of increased metabolic activity. Right, so bone scan may not necessarily be the best study, but it can help you, if you need it, to differentiate between some conditions as well. So I will tell you that bone scans, we don't really get them in orthopedics, right? But we rely more so on the MRI, okay? And the imaging, correct? You always get baseline x-rays. That's the answer, right? And then if you're concerned, you get an MRI with contrast. Would you ever get an MRI without contrast if you're concerned about bone infection? In this case, the answer is no. Okay? Are we on the same page? Okay. I just mentioned the bone scan because your book talks about it. Okay? So what if you have an incidental area of uptake and you see it on a bone scan, then maybe it deserves further investigation. Okay? Osteomyelitis treatment. I gave you this picture here. I want you to memorize this picture, right? And I want you to make sure that you understand. No, I'm joking. So I added that so you guys understand that, that osteomyelitis is not just osteomyelitis. Getting to the question that Mr. Frazier had, even if you made the diagnosis, the treatment can be different depending on the extent of the osteomyelitis. Okay, so just making the diagnosis itself is not enough, right? Then you have to stage it, figure out how significant it is, figure out the full involvement of it, doesn't involve the joint, right? And then treat it accordingly, okay? If you decide that you staged it and it's not, and say it's what, superficial like it says there, then maybe you can do a trial of antibiotics. And do what? Follow the labs. Use serial physical examinations, right? So you're following this out to see if it improves. But once you decide that it's not just superficial, and now you've moved on more so to these last two stages, especially the stage 4, right? Then you've decided we need to do something about it, and surgery can be indicated. Notice how I keep saying the word indicated? Indicated is something means that it is supposed to be, or your clinical suspicion, your physical exam, your imaging has led you to believe that you need to do surgery for this. It's indicated, okay? Do we just operate on everybody? No. Because guess what? You just took badness that was localized to one little area, made an incision, spread stuff out, violated certain areas, certain fascia, certain planes of tissue, and now you just move all that infection into all those other areas too. Make sense? So important to understand what you're treating and what stage it's at. I will not ask you the stages, okay? I just thought that was helpful. Okay? So what do we do in surgery? Well, you got to debride it. Everybody understands what debridement means? Clean, clean, clean. Right? Take away bad tissue. Does that look like gnarly nastiness there? Yeah. So afterwards, it looks like this. That's pretty extensive, maybe. That looks like they did a lot of whacking, a lot of chopping, slicing, dicing, debridement. That's what we're talking about. Okay. You take it down. Take all that non-viable tissue, all that dead tissue if it's present, and get to a point where you have clean areas of the wound, and therefore you try to remove as much of that infection as possible. That's what debridement is, okay? Make sense? Okay, is there a lot of irrigation going on with this too? Yeah, so sometimes, let me just finish this one thing and I'll answer. So sometimes you'll see that we say the word irrigation and debridement. Meaning that not only are you taking tissue, cutting things down, taking away things that are infected or non-viable, but you're wash, clean, clean, clean. So a lot of fluid, okay? Normal saline, etc. Okay? Sir, what's your question? For which one? Non-operative, yeah. So if you're going to start antibiotics and you're watching, I'm sorry, his question is really good. Mr. Daniels? Captain Daniels? Yes, okay. So his question is really good. So if you're doing antibiotics, watchful waiting as we call it, right, surveillance if you will, are you going to admit them? Yes, you are. You would never send somebody home that you suspect could have osteomyelitis, but you are just treating to see if they improve, or that it's not significant, right? Because if you send them home and say, come back and see me in 2 weeks, what might they look like when they come back in 2 weeks? different, worse, not good, right? But more importantly, if you're gonna start antibiotics, what's the two-letter, what's that right there? You're gonna send somebody home with IV antibiotics? No, right? ER does play some trickery, have people come in, get a bag, go back home, come in, get a bag, go back home. But in the surgery world, we don't do that, okay? So that is a very good question, Captain Daniels. You will admit those patients, and you will continue to do morning labs, right, to see if they improve, checking that CRP. Incidentally, when you guys get into other courses, like I said, you will get knowledge that there are calculators or indexes that you're going to check to see whether or not there's a high level of high likelihood that certain conditions are present. Do you think CRP is one of those factors for osteomyelitis? Yes, also one of those factors for, septic arthritis, okay? But just one factor, right? There's other factors, okay? Severe comorbidities, so usually what we're talking about here is diabetes. My blood, my sugars, sir, my sugars, doc, the sugars got me, right? So diabetes, you know, if you, somebody was, I was having a conversation with somebody, sorry I'm old, I don't remember who it was, but they were saying, well, why would you amputate, right? I remember who it was now. She's right there. Why would you amputate? You know, why on earth would you amputate? Well, this can be considered a form of amputation, correct? You're just taking a little bit of the area. Say the infection continues to spread. Then we start taking toes. We start taking metatarsals, right? Then it works its way up to the ankle. Then we take the whole foot, right? Then it works its way up to the mid-tibia. Then we do a below knee amputation. Then it works its way up closer to the knee joint. Then we do a above knee amputation. Okay, you see what I'm getting at, right? The more sometimes you have to get more aggressive about staving off the infection wherever it is before it progresses to other areas. So in diabetes, do you think those crazy uncontrolled blood sugars, that party lifestyle, that blood sugar of 1200, and all those other things that like smoking, all those things got going on, puts them at a higher risk for possible amputations? 1,575%. Okay, are we good there? Excellent question, I like it. So my first, I've probably been a surgery fellow for about, I don't know, a couple weeks, I didn't know anything, right? And they called me and said there was I was at Portsmouth in Norfolk, right, Navy, and they called me from Langley, me, the guy with the pager, right, the guy who doesn't know a damn thing, right, and they said, hey, I got this guy, right, it's always this guy or this kiddo, and he's an uncontrolled diabetic. Oh, by the way, he's a pilot. I'm like, oh, he's not on flight status anymore. No, he's retired. Okay, got it. So older gentleman, got it. Seasoned, I should say. And he's having fevers and all this. He tells me this whole story about how he's got this open wound on his foot and all this craziness. Fast forward, right? We did this, okay, something similar to that. Then we took out 2 of his metatarsals, and then we took the whole thing, right? So again, the level of presentation, you'll see people that have these nasty wounds, and you're like, how do they let this go on? They just do, right? When you have diabetes, right, do you lose sensation in that area too? Right, so again, do not fall into the pain trap. He was actually relatively painless. The reason he really presented to the primary care clinic at Langley was because he couldn't walk on it anymore, because his foot was freaking falling apart internally, right? So it was collapsing essentially. Make sense? So by the time I saw him, right, and I'm doing all these crazy tests, and I got all the crazy labs, we were just whacking. We call them ray resections, right? Rays like the metatarsal, the phalanges, all that. So you start slow, low and slow, and then if you have to, you start taking bigger areas, okay? Make sense? So his presentation was actually, to him, it was very benign. It's like, you just can't walk it anymore because it just doesn't feel right. But believe it or not, he wasn't even in that much pain. And he didn't really have fevers. He said every once in a while he felt warm, but man, the area was lit up, I can tell you that much. It looked like a shopping mall during Christmas time. Okay? Hopefully that example helps you. Okay, so outcomes of disease, obviously, even if you treat it, can it come back? Yes. Even if you treat it, can it still kind of live in that area? Yes. Okay, so that's why I'm going to say refractory. You'll see with patients with diabetes, they kind of do this, right? They have these wounds, you treat them appropriately, they get better, you do antibiotics, they seem to do well, then they come back, and the wound just never closed all the way. Okay, so again, it can kind of wax and wane, if you will. Make sense? Their medical status will decide a lot of times what their prognosis is, right? So again, diabetes, peripheral vascular disease, smoking, malnutrition, immunosuppression, right? If you're immunosuppressed, we already talked about this, are you more likely to have more serious infections that do not respond well to typical treatment? Yes. That's why there's a whole specialty called infectious disease that exists, right, to treat that stuff. The stuff that just doesn't get better sometimes, okay? So in orthopedics, do I have especially if you work total joints, true story at the academy, right? The lady, the civilian who was our infectious disease, our ID consultant, I knew her well. I bought her a Christmas card, right? Because she would always help us out to figure out if this was badness or whether we could just treat with regular antibiotics and go about our business and watch them improve. And so again, just because we're ortho doesn't mean that we just manage all this on our own. So chronic osteomyelitis, then you have metaplasia, metaplastic conversion, right? And SCC develops, right? So skin changes, right? Cell changes, cellular changes, excuse me. You guys remember all these metaplasias, hyperplasias, differences? Okay. Then you can have something that develops called a marginal ulcer. I just mentioned that because your book brings it up. Okay, so that is kind of an atypical progression, but it can certainly exist. Okay, so I urge you just to read a little bit more about it in your textbook or in your highlighted reading, but don't become too focused on that. Okay, good to go. Okay. Pediatrics, you have chronic. You can have chronic OM as well, right? You can have bone loss, joint destruction. If you have infection in proximal femur and they have sustained an actual fracture, that's bad, correct? So, so they can have pathologic fractures that are secondary to infection as well, versus tumors, correct? And then fascial arrest. I want to go ahead and take a second just to talk about this in the next 30 seconds. What is the physis? Is that the area of growth of a bone? Yes. So in kids, that's super important, correct? So if an infection involves the physis and it's not adequately treated, or if it's treated and then they go on to have fascial arrest, which means they don't have normal continued bone growth and development, can that lead to significant long-term complications? Absolutely 100%. So if you I treat a patient for chronic osteomyelitis, pediatric patient, I'm going to continue to see that patient even after they show signs of improvement, just to make sure that the bone continues to grow, lengthen, for example, and that the patient has normal physiological development. Okay, good to go? So you're going to get x-rays, more x-rays, and more x-rays? Yes, you're just going to continue to follow out their growth patterns. That's what it's talking about there. So fascial arrest, bad thing. That's not good. Okay? Any questions about that? You guys already know about physis and epiphysis and metaphysis and all that stuff, right? Okay. You get into it more in block 4 as well. But you should be concerned about fascial arrest. That's the reason why it's in bold gold, correct? All right, so don't overlook that. Okay. I'm going to go ahead and put you on break now so we can move on to the next topic, and then we'll come back. You guys want a nice long break? You want like 10 mics or 10? Okay, 10 mics, we'll get started. That's a good question.
I'm older than you. I am. That's all. That's small portion.
Yes.
Well, I think we got a good chance. Yeah, I just looked at who we all one year, 2017, we always play we always like 5th and 6th, maybe 17 coming I would prefer yeah. She's like, so it's like, I offered some salt. I'm not fridges and yeah, like she's a lot. As you're going down that line, NFL Sunday ticket to switch the Chargers joke. We made the playoffs. I invested another week in my life.
Several months off.
Back in my head, I was on like start ice. I'm like, see, throwing that like in the back. I went back for a while. You know, like it's actually coming up way quicker than I thought. The first test, yeah, right after you and cardio was like that Monday after. Yeah, I thought I won't. At least not teaching. That other guy. I don't know if he's still teaching military public health. In the sense that, remember Colonel was Ranger Bond and I like the one professional picture from that one. And then uncut, he actually had my wife on the front when we were and it had that one with and an open all of the so we know it's not just Kowski, not Dr. Mercer, that other guy was falling. So they probably the same thing more back to like habits.
I know he's getting into the rest of
Yeah.
but then now that other guy.
That's like other candidates and the others you think about all these actors, they're all like of the program itself. Like the highest rate they have. But he's also going to on like what is that tablet? Like how I'm looking at it. Oh no, yeah, that sounds down to
Yeah. Alright, so I guess I know, right?
Placebo is real, boys. Is that all?
That's funny because they definitely said that during the game is right last month, and I just really trying to get that. Trying to get our. I made Sierra. I like made her sick. I think it was like I'm trusting the systems as well.
They said gold mold is pretty good.
But like, so I'm just trusting the system. The other guys,
Yeah, so like, what is the system? Yeah, what is the system? What system?
You guys ready? All right. So we're getting some really good questions. I think I was clicking on the clicker as I was talking. We're getting some really good questions, and I hope you guys understand that when it comes to talking about, especially the pediatric population, God forbid you're working up in neonate, right? That it's not straightforward. Okay, you can't follow this linear progression. You have to make sure you get all your labs. You have to make sure you get your physical exam complete, and you have to make sure you get your proper imaging. Okay. So the big thing, if you go back to that slide where in bold gold it says prior to antibiotics, let's just break this down real quick. So are you going to hold antibiotics until you get the culture results back? No. All that's saying to you is you get the cultures quickly, right? Timely. And then you initiate antibiotics based on what you suspect is going on, right? Because it could take days to get final reports for those cultures, correct? Days, okay? So again, it's not that you're holding the antibiotics indefinitely, it's just that you're getting the cultures plus or minus biopsies. It says biopsy because what if it's a superficial soft tissue? Can you get in there and just take a chunk of it pretty easy without doing this big open operative procedure? Yes. But if you start antibiotics and then send that to the lab, right, and you put that in the history, maybe the results aren't as helpful. Make sense? You guys understand that concept? I don't want to go too deep into that because we can spend a lot of time on that. But you guys are getting the sense that infection can be challenging to address and to deal with, right? Especially in neonates and pediatric patients. Okay? You're going to lose a lot of sleep sometime in the near future trying to figure out, did I do the right thing? Sending that patient home? I don't know. Right? How many nights in fellowship do you think? Because do you think in fellowship level, or even in phase 2 sometimes, when you're working with like a second-year resident, are the attendings in the hospital at night? No. I was doing a lot of stuff on my own as a second-year resident, right? Because that's what you become as a fellow. Where it was just me and him. Yeah, one of us knew more than the other. Sometimes it was reversed, and I knew more than the guy I was working with, the girl I was working with, because they just weren't very good, right? Or just very attentive. But a lot of times you're just kind of like, what do you think? I don't know, what do you think? Should we admit the patient? That's a big deal to admit the patient. Do you admit a patient as a phase 2 student? No, you admit them under the provider, correct? With the resident, obviously. But they admit them under the attending, who may not even see that patient until the next day. The only reason an orthopedic surgeon comes to the hospital at 10 o'clock at night is to do what? Surgery, the Lord's work, right? So you may admit a patient, right? And then you're like, I was concerned about it. We got all these cultures, we got all these labs. The CRP wasn't too high. You know, I was able to go down there and take him off the bed, and he stood on the extremity for 3 seconds. Yeah, it bothered him, and it didn't seem very comfortable with it, but we admitted him. We consulted IV. We started broad spectrum antibiotics. Everything's pending. This is what you're telling the attending the next morning at 06:30, 07:30 in the morning, right? And then he's going to go see that patient, and he's going to look at you and say, what happened here? This patient looks perfectly fine. And then you're going to bring up the labs. And you're like, this is my suspicion, sir, based on this is my exam. Oh, and look at the imaging, you have some evidence of periosteal elevation. Okay, fair enough. They back off, right? Because you had, your clinical suspicion was based on your diagnostics, not just, well, I'm gonna admit every kid that has hip pain. Good luck with that, right? Because you're gonna admit a lot of kids that don't need surgical intervention or surgical monitoring, surveillance, if you will. Okay, that's not to say you shouldn't have a level of clinical suspicion though. Was that helpful at all? I hope so. Because your paranoia will become real eventually if you're working in the inpatient setting or in the surgical setting for sure. All right? Again, you call me on the phone and tell me somebody cut their finger, the one refuses to heal, it's been open for 3 or 4 weeks. What's the first thing in my mind? Infection. And then I work backwards. Okay? Make sense? Okay, now we talk about more infection. So septic, that's bad, right? Right? Again, septic arthritis is not sepsis. Sepsis is blood. Infections throughout the whole body. Patient is not doing well. Okay? Septic arthritis is literally infection in the joint. Okay? That is now destroying what? Cartilage, bone, everything that it can get its hands on. Okay? So infection of the joint space is your nice little clean definition. Okay? So in pediatrics, again, underlined, what's the most common spread?
What?
Hematogenous spread. Okay? Most common organism, again? Staph aureus. And there it is. It can be caused by adjacent metaphyseal osteomyelitis or rarely penetrating wounds. So in kids, normally it is contiguous spreading up the bone. It gets to the joint and now goes from osteomyelitis to potentially septic arthritis if it started with osteomyelitis. You guys understand this difference? Because that is important to distinguish. Just because you have septic arthritis doesn't mean you have osteomyelitis. And just because you have osteomyelitis doesn't mean it can't become septic arthritis. Okay? Make sense? So remember we talked about osteomyelitis. The infection is in the bone marrow, correct? And the examples that we used. So where are you going to go after the samples? The bone marrow. Now, in this case, the infection is in the joint, correct? So where are you going to go after the analysis in septic arthritis? The joint space. So don't get those two confused, okay? So kids, again, rarely penetrating trauma. So usually, do we get an MRI with contrast to kind of see, did this come from somewhere else adjacent? Yes, because kids can be challenging to do a history on and to do a physical exam on. We keep talking about that. And trust me, you will be living it soon, right? So don't miss the underlying infection and don't miss the progression of septic arthritis. Okay? So in adults, there's some zingers out there, right? But etiology, direct inoculation, or hematogenous spread, what that means is if they have a large penetrating wound that's near the hip, correct? Could it get into the joint capsule? Yes. If you have a penetrating wound around the elbow, could it get into the elbow joint? Yes. So sometimes the answer may be staring in the face as far as where it came from, okay? But it can also be an extension of osteomyelitis versus cellulitis. You guys do understand that when we talk about cellulitis, that's that superficial infection, right? Okay, that's the superficial stuff. So can the superficial stuff now become deeper stuff and move into the word stuff isn't good, right? But deeper infection. So yes, and then it can progress to septic arthritis. Good to go? Okay. Don't get those two confused, guys. And don't miss one just because you have the other. All right? So what's the most common erosion in adults again? Staph aureus. Just to throw it in there, right? IV drug users, what is another variant that you need to be careful about and get a good history? Which one? Pseudomonas aeruginosa. Okay, pseudomonas. Okay, so are the treatments different if you have pseudomonas versus just staph? Yes. Different antibiotics. Yes, sir.
When you're taking an aspiration, what position do you have the joint? Like
for?
It depends on the, okay, so his question was a good question, but I wish you were with me in phase 2, because then I would just make you do the aspiration, so you could never forget why and how. Right, but his question was, what position would you have a particular joint in when you're doing an aspiration, okay? When you're, if you're in phase 2 and you ask that question, I'm like, oh, well, let's go find out. And then you double gulp and then realize you're doing it, okay? So, but for knees, you want to get into the knee joint itself without going through any tissue, any planes that are infected that could have seeded deeper, right? So what does that mean? That means you have a big gaping wound in the knee, and now you're concerned that that wound is not just cellulitis, but it has seeded down to the joint. Whatever position you put that patient in, you want to make sure you don't go through planes or areas of tissue that are infected, and then take that infection and traverse it down into the joint. So that's your general guidelines, okay? Same thing with the elbow. If somebody has, everybody knows what your olecranon is, right? If you don't, I'll give you a lecture on it, okay? But that's this thing right here, the tip of your elbow, okay? Is there a bursa there? There is. I'll tell you my horror story later during upper extremity. I'm going to save it. But if somebody has olecranon bursitis and you're deciding upon yourself, you're going to aspirate that, right? Whether it be to take the fluid out and to provide, I'm going to put my arm down, and provide the patient with some level of comfort, right? And then send that fluid, and you stick that needle all the way into the elbow joint. You just took the bursa, the contents of the bursa, and introduced it into the elbow joint. Okay? Is that bad? So I will tell you to answer your question, right? Whatever position you put the patient in, depending on the body part, right? Make sure you're not going through planes of infection, if you will, or areas of concern, right? As you just try to advance your needle into that joint space. So that's your general answer, okay? All right. Let me know where you go to rotation. I'll make sure your preceptor is ready for you to have to do aspirations. All right. That's a joke, sort of. All right, so clinical symptoms, pediatrics. So again, guarding of the involved joint. Gosh, this sounds like osteomyelitis or the proximal metaphysis. How do I differentiate it? Right? Pain poorly localized initially. If it's lower extremity, they refuse to bear weight or they limp. Okay? If it's upper extremity, if a pediatric patient elbow is septic, do you think they're going to want to use that arm? No. So they may move with the shoulder, they may move with the wrist and hand, but they definitely don't want to move with the elbow. Okay? Fever, that's in red. Remember, in osteomyelitis, you could or could not have fever. In this case, you have fever, right? It's in red, right? Anytime you see something in red, and we're talking about a surgical consideration, should you call orthopedics? Yes, you have my permission to. Please do, early. Okay, malaise, what does that mean? Just generally don't feel good, right? Like you did this morning at about 7:52. Okay? Loss of appetite. Do kids with infection want to eat? Nah. Right? So they won't eat, right? So maybe if they're, I'm not going to pass judgment, but let's say that they're taking a bottle still, and they're like older pediatric patient. It's a choice, right? And now they don't want to take a bottle. Is that a piece of information that's pertinent? That's in the history, okay? You're putting all these pieces of the puzzle together. Okay? What's in red, refer to ortho. Then I move over to adults. Painful, restricted range of motion. Okay? What does that mean? So you're going to learn, right, as we go through these different body parts, that every area of the body has a particular range of motion. So if you have a decrease of range of motion in a certain range versus the contralateral unaffected side, could that be significant? Okay? Right? So it doesn't mean that it's absent, it just means it's restricted or less. Good to go? Okay. Warmth? Oof. All right, red. Joint tenderness? All right? So I think that should be red too, but it's not as specific, right? Because can you have patients that have meniscal tears, meniscal pathology in adults, and they have pain in their joint line? Sure. But if they got warmth, right? And you have this wound around the knee, and you're concerned about it, right? It was a week ago, and now they got a warm, swollen, there's the effusion, joint, restricted range of motion compared to the contralateral side, and it's red, do you think that you should be concerned about infection? 100%. So all roads leading to the bottom of that slide again refer to ortho. Okay? One of my last patients I saw when I was in Misawa, I didn't mention that. I just came from Misawa Air Base, Japan. You know, I was there by myself for 3 years, primary trauma call. Okay? Everything that came in, I was the only PA in the northeastern portion of Japan, period, that did orthopedics, orthopedic surgery. And I got phone calls with all kinds of weird stuff. But I get a phone call from the ER saying that a guy jumped off the seawall and he's got 2 large gaping wounds in the anterior aspect of his knee, okay, and proximal tibia. Now, is it okay to just close it up and send the patient home? Like, so you're saying, so you sent me, I said, you know what? I'll play along. All right, you didn't get any labs, did you? No? Okay. Did you get any imaging? No? All right, I'll play along. Send me a picture. I got it on my phone if you want to see it. I got like 10 years of pictures on my phone. It's like a horror show, right? But basically, I looked at it and I was like, ooh, that looks bad. He jumped off a seawall. Everybody knows what a seawall is?
One of those that breaks.
Yeah, it breaks the tide, it breaks the, on the coastal area. So sometimes they're artificial, sometimes they're just based on land formations. Okay, but basically in Misawa they have these seawalls that they create to break the surf. Okay, and so they build these, and they're a mixture of either rock or some kind of metallic. Right? This dude decided, yes, it was alcohol involved. This dude decided he was going to jump off the seawall and down into the water. Well, guess what? The tide went out. When he jumped, he landed knee first, right? Maybe not knee first, probably hit his head first, but and gashed his knee. Okay, so now I'm talking about like the concern for the fact that it was ocean water, right? Because that has different bugs in it. Okay, I won't talk about antibiotic selection. But this dude just limped to the ER and he's just bleeding everywhere. He left a bloody sock trail to the bed, and I took one look at him, quickly decided there's some alcohol involved here, and then did what? I said, let's get the labs, let's get the imaging, let's get a set of vitals, okay? Let me do a physical exam, right? I have to now decide, is it just those open wounds? I mean, I can see a lot there, right? I did an irrigation and debridement, got all the nasty seawall remnants, ocean water, beer top, whatever was in there, right? And I was able to observe the margins of the wound, and I decided that was deep, right? So I had to figure out if it's infection into the joint capsule. Well, how do you do that? Once you clean it up, open it up, explored it, you put a sterile glove on, you set up a sterile field, and you literally, I don't want to be graphic, but you put your finger in there, and you feel whether or not you can get into the joint. If you can get into the joint, guess what? It communicates with the joint, right? Because if we just close them up and send them home, and this wound now communicates to the joint, he'll be back, and he'll be worse, right? He's going to go home to start getting this septic arthritis progression. Make sense? Did I get imaging? I did get imaging, okay? And I called the radiologist. Hard to find him. But I called him and I said, hey, do you think it violates the joint capsule? And he said, I don't know. I said, great, thank you. Super helpful, right? But I needed to know whether or not that wound violated the joint capsule. So the whole point of this story is that did he present with fevers, warmth, tenderness? Did he present with any of that? No, but he had this large gaping wound. And if you want to see the pictures, I'll show you. They're large, right? So do you think it's acceptable to just clean, and then just close those wounds and call it a day if it involves a joint? No. So you still need to be suspicious about it, even if it's presenting, especially if it's presenting, immediately after injury, because if it violates the joint capsule, don't worry, they'll be back. Right? After tissue's been destroyed, what? Cartilage, bone, etc. Okay? Was that helpful at all? Yeah. No? Okay. All right, so but when this presents, you shouldn't miss this. That looks like an angry joint, correct? This fits the textbook, if you will, right? So red, hot, swollen joint is infection, right? Infection of the joint. Is that overlying the knee? Yes, okay? And the common sites, knee is most common, okay? So you're gonna see a lot of knee, all right? Severe pain with range of motion. So we call, the word we use in orthopedics, at least or in the surgical ward, is exquisite tenderness. Exquisite sounds like it's something like super exotic, right? It just means not good, really bad, right? We don't like the word severe. As primary care, you'll probably use that word a lot. Severe. What does severe pain mean? How do you qualify that? Wakes you up at night? Okay. All right. So we don't really use the word severe. I'm not saying you're wrong, sir. Yeah. So that may be severe pain. But it's more so, what does the pain limit? Severe pain with weight bearing and axial loading. That's more significant. Okay? I use the word significant, right? So if a patient has significant pain with range of motion and is refusing to bear weight and has this clinical picture here that you see there, right, hot swollen joint, what does the bottom tell you to do? Refer to ortho. Okay? If you're in the primary care setting, how do you deal with that? Send them to the urgent care, probably the ER. So does an ER associated with an inpatient capability? Yes, because they may need to be admitted, correct? All right. Remember how I told you in that patient that presented, I went ahead, God, I wish I could use this term, but I'll be recorded. But I put my finger deep in there. I felt all up in there. I was deep, okay? And if that patient, if I had been able to put my finger into a joint, what do you think we would have done then? I numbed him up, don't worry. Okay? You admit him, and you take him to the operating room, and you make big incisions, and you do an irrigation and debridement. You got to get the badness out before it does more havoc, right? So if you get a patient that presents later on and has this, right? Say that patient I come back 2 weeks later, now he had this. What do? You admit him, right? You do all the stuff you're supposed to do prior to antibiotics, right? You put the signed consent on the chart, and you take him to the Lord's suite, right? Where you do the Lord's work, right? You do an irrigation and debridement. So so that's the same in the surgical world, right? So again, when you call me, I'm making a point here, I promise. When you call me and you tell me you think you have a surgical patient, and you didn't get the labs, right? You didn't get the imaging. You haven't really seen the patient yet. Right? You're just listening to what your medic is telling you that the patient is in room 4, right? I'm going to be sad. Because all these things that I'm talking about and that I'm lecturing about and that I'm emphasizing are necessary to determine if there is a surgical indication. Does that make sense? So how do you work up a patient? What's the difference between working up a patient for a potentially surgical problem, surgical condition in primary care versus ER versus anywhere else? Resources, right? But doesn't change. So if you don't have the proper resources, you send that patient wherever they need to go to get that proper evaluation. Does that make sense? Okay? There's no difference. Surgical evaluation, whether it's done in primary care or in the surgical setting, is the same. It doesn't change. You don't cut corners just because you're in a primary care setting. Make sense? There's a lesson there somewhere. Okay, septic arthritis, laboratory, ESR, CRP again, right? Blood cell, blood cultures, 5 to antibiotics, correct? Nothing changes. So CRP greater than 10.5, what? Milligrams per liter, okay? Don't let that throw you off. There's a power. Sometimes you guys, when you guys start talking more so about labs and other courses, especially in like EM, for example, it's important to know the units of measurement, right? Because the number will change based on where the decimal point goes, right? So this is 10.5 milligrams per liter. If it's deciliter, it's been reported out in, then you have to understand what that power is, right? Because the number changes, correct? Everybody understands what I mean by that concept? Understand the unit of measurement, okay? Because you'll see that very commonly for ESR and CRP, depending on whether one unit of measurement is used or another, can be whether or not that number is significant. Don't let that be the sole thing that you miss, and realize, ooh, I was actually supposed to look at this in milligrams per liter. That's significant. Okay, good to go? but it's the most predicted value for septic arthritis. So where do you think that comes from? That comes from that calculation I was telling you guys about. Okay? That's just one component of it. But if you were to take the CRP as one factor for septic arthritis, and it comes back greater than 10.5, do you think that patient has just bought themselves a trip to the operating room with a red hot swollen joint? 100%. That's what that means. Okay? So, and again, like we talked about, CRP is useful in engaging response to treatment. Okay? Joint aspirate, all right, this is where we transition. So we're talking about actually going in there and getting fluid out of the joint, right? So this is to address Mr. Deloach, right? OC Deloach. So this is the position that I do aspirations in, okay? But are there other ways to do it? Sure. All right, there's a number of things that we'll get into. I would say, well, maybe you guys will see me. If you go to BAMC, you may see me. I do clinic over there. I go to the operating room there. So if you go to BAMC, you may turn around and say, oh, shoot, here it comes, right? But because I work over there. But I'm just saying, if your preceptor says, let's do an aspirate, and you see them put the patient in this position, they're not doing it wrong, okay? All right? There's a number of reasons. But usually this is safe because the wounds are usually anterior. Do people fall and directly onto their knee a lot? Yes, you may have a big gaping wound there. But it's also easier to get into the joint capsule this way. And if you have significant swelling, don't worry, you'll figure out this is the easiest way to do it. But look at that fluid that's in that syringe. Does that look like straw-colored, light-colored? No, that looks chunky monkey, right? There appears to be fluid that's not normal synovial fluid. What is normal synovial fluid? Well, you got to see it first, right? But after you've seen it a few times, you'll know. Okay, when you pull back and you have cloudy, chunky monkey in that syringe, and you take it out of the knee joint, take the needle off, put the cap on it, hand it to your medic, you're like, ugh, this is not gonna end well, right? You know right away. So is one of the measures of your analysis the color of the fluid? It is. Okay, so don't forget about that too. Okay, because if you call me, excuse me, and you took it upon yourself to do an aspirate, the results are pending, correct? What do you think I'm going to ask you? What did the fluid look like? Did you taste it? Right? Just kidding. This is not Dr. House, right? You can't taste it and figure out what the diagnosis is. But I'm going to ask you, because that's the only piece of information I'm going to get right now, correct? All right? So sometimes we'll ask you if it was bloody, but that just could be for your technique too. A bloody tap. So, sorry.
Can you explain the difference in the clinical presentation between septic arthritis and bursitis?
Yes, I will. You want me to do it right now?
I was hoping so.
Okay. All right. So we'll get there. It may throw us off today, but again, we're good, right? But so his question was, it's deep, because that's a whole other subject. That's a whole other topic for a reason, right? So his question was, can I explain the difference between bursitis and septic arthritis? Okay. Yes, I can. You want the quick one?
Yes.
Okay. Here's the quick one. If it's bursitis, it only involves a bursa. If it's septic arthritis, it involves a joint, right? If it's bursitis that has now become septic arthritis, it involves both. But is it usually septic arthritis that moves on to be bursitis? Who cares? The joint is already infected. Make sense? All right? Good to go? Are you okay with that definition for now?
Yes, sir.
You want more?
No, sir.
I got more. All right, but that's the thing. So what I mean by that is, and especially if you had a traumatic tap, right, where you took that needle and went through not only the areas of devitalized tissue or infected areas, but you violated a bursa and kept on going and ended up in the knee joint, then it's all involved. But the big thing is that patient has bought themselves a trip to the operating room, because do we just we make a nice big incision, right? We can do it arthroscopically too, but let's not go there. But we make a nice big incision and we look. We look at everything. We look underneath the kneecap. We look a lot of different places. It's not just a very small little poke hole. We're going after it, guys. We're trying to get the chunky monkey out of there. Okay? Good to go? Are you happy with that for now?
Yes, sir.
Okay. I'll give you more, don't worry. Then you'll be like, please stop. So a joint aspirate though, it's important to understand that now we're talking about taking the fluid directly out of the joint. So when you analyze that fluid, don't get that tripped up with the parameters of the lab values for a serum, okay, because they're different, right? So you'll get crystals. Why? Is gout potentially a diagnosis for a red house swollen joint? It could be. Okay. Gram stains, looking for the bugs, right? Culture and sensitivity. Okay, remember I told you you take the cultures, right? But then you send it to the lab, and the lab grows it out to see what it grows, and also does analysis to see what it responds to as far as antibiotics. Does that take time? Yes. That's why a lot of times you hear the term used empiric antibiotics, meaning it covers for the common bugs, like what we discussed, but also kind of shoots in a wider range to cover for some potentially atypicals as well, right? So when you get that culture and sensitivity back, and you realize the patient is getting better, but not, you're like, why aren't they getting better? Then it grows out a bug that you're like, ooh. You call it infectious disease, and you're like, hey, it grew out this. And they say, oh, yeah, you need to add this other medication too. So you don't get that? You started with some empiric antibiotics, and now you're focusing fire on the enemy that you have targeted. You've targeted the bug, okay? Make sense? So don't be surprised if you have to modify, say you're on your inpatient rotations, right? God help you. But you're on an inpatient rotation, right? And you're like, why are we modifying antibiotics? Go look at the culture sensitivity and be like, oh, that's why. It came back as this, and it recommends this, and ID made this recommendation. ID being infectious disease, okay? Blood counts, okay, complete blood counts. Okay, again, those are not to be confused with the serum, correct? Proteins and glucose. Does infection love glucose? It loves it. It eats it for breakfast. It uses it to grow, right? What makes the grass grow? Blood. What makes infection grow? Glucose, okay? So, what might an infected joint come back with a low glucose count? Yes. So that's an example. And let's not go down to lab because then you're like, ooh, my brain is swelling. Okay? But when you're saying criteria, again, these criteria for diagnosis, white blood cell count greater than 50,000 cubic millimeters, right, is infection. That is infection. That's all you need to know. Okay? Do we have different criteria in surgery world? Sure. But this is 90% specific and 56% sensitive. So is there a chance that it may not be infection? There is, but it is infection. Let us decide as a surgical specialty whether or not we're going to take them to the operating room. But if you get a count back in the ER, for example, if you rotate under, and it's 50,000 cubic millimeters, right? That's a threshold. You have now crossed over into 7. Okay? Same thing with the synovial white blood cell count, greater than 90%. It's greater than 25,000 PMNs, right? That is infection, right? But even more so. So not only do you have the white blood cell count, but greater than 25,000 PMNs, that's in that complete count, right? The answer is yes, by the way. Okay? So you put those two pieces of information together and say, and a low glucose, ooh, I think there's a high likelihood this is infection. Make sense? You see how that works, right? You don't just do one test. You do all the tests. Then you lay them out on the table, and you say, all right, let's see what's going on here. All right, same thing you're going to do on pants. You're going to be clicking those screens, bringing up five screens, going back and forth with these lab values, trying to decide if it's normal or is abnormal. Okay? So if you're going to do operative treatment, right, a lot of times, unless it's just staring at you in the face, we're going to get aspirations. Okay? Because we're trying to figure out, is this patient going to the operating room? Okay? All right? So, and obtain blood cultures. This is in order. Notice I told you that I was always going to tell you if things went in order. There's number 1, there's number 2, and there's number 3. So hopefully this gets more to your question, O.C. Frazier, about, kind of like stepwise, right? So you're going to get an aspirate of the joint. You're going to send it for cultures, right? Or you're going to get cultures as well. Okay, blood cultures, right? Aspirate and blood cultures are different, correct? Right? So it's a twofold attack, two-prong attack, okay? Then you're gonna start empiric antibiotics. Did I miss a letter, 2 letters there? IV antibiotics. So is that patient likely going home? No. They may not go to the operating room right away, but they're not going home, okay? So then you're gonna do, if it's indicated, then you're gonna do a surgical incision. So you're gonna make incisions. It has now become an open procedure, like we talked about on day 1, correct? And drainage. And that is done on an emergent basis. Meaning you don't just send the patient home and say, here, take these pills by mouth. Let's see how you do. Unless you hate the patient, right? You see that chunky monkey that's coming out of that, the end of that, right? That's an arthroscopic debridement. We put that into the joint and we're running tons and tons of fluid through there. You see how it's coming out? Right? It looks juicy, doesn't it? A little bit of blood in there. You know, some of that can be from the incision that we make to put those instruments in. But then, does that look normal? How would you know? Right? You haven't seen synovial fluid, but it's thick, viscous, not clear. It's hazy, cloudy, right? It just doesn't look normal. It may have a smell to it. Right? You never forget that smell of Pseudomonas if you've never smelled it. Okay? Right? Right. So does that look normal? Who said yes? All right, so that's not normal, right? That looks like badness has occurred. Would you just nail that down to cellulitis? No. What's the principle I've been teaching you guys? It's infection until otherwise proven, right? So if you think it's an infection, are you at least going to get some baseline labs? Yes. Are you going to do an aspiration necessarily? No, not necessarily, right? But again, these are all things you're considering. But before you decide that the patient needs surgery or that they need IV antibiotics, you're going to do this, correct? You see the difference I'm trying to make here? Okay. What if it is cellulitis? Do you need to do all this and aspirate? You've just taken an area of cellulitis and introduced it into the joint. That's bad. You see what I'm getting at? So you need to decide for yourself as a provider, how bad do I think this is, and does this need to be ruled out? All right? You're going to see a lot of patients that are sitting in the ER, rule out infection. It literally just says that. A condition, an injury pattern, and then rule out infection. All right? Patients are on the floor. All right? They got admitted as part of a rule out infection. And we're watching them to see if they improve. If they don't, again, we take them to the operating room and do the business. Okay? Make sense? But is that a routine consult or an emergent consult? Is the only point of this slide. Emergent, meaning now. Okay? So if you need to wake somebody up, wake somebody up. All right? So any questions about that? Okay. That's infection. Hopefully, again, by the time you're done with my course, you have a healthy respect for the need to rule out infection. Okay? You call me and tell me somebody had open fracture, right? And now they have a red hot swollen joint. What's the first question I'm going to ask you? Did you get labs? Yeah, it's simple stuff. You know what I'm saying? But don't be surprised. Don't worry. I get phone calls still about patients. They forgot I left massage. I get crazy like emails and stuff in my personal email saying, hey, I got some of this patient yesterday in clinic. Do you think I should be worried about infection? I'm thinking to myself, you should have been worried about infection yesterday, right? Not right now that you got some lab results back. I'm like, that's craziness to me. So, but anyway. All right. Any questions about osteomyelitis versus septic arthritis? We're going to cover osteoporosis real quick. You guys have covered this already a little bit, I understand. Okay, so we understand that osteoporosis is a design issue, right? Where the microarchitectural deterioration is present, the bone mineral density is decreased, and it places the patient at risk for fracture. All that makes sense, correct? If a patient has decreased bone mineral density, their bone is not as strong, therefore they can be fractures. Okay? There's 2 different kinds, primary or secondary. Primary, women it's more common, 6 times more common, right? Right? No, I don't want to get anger and hate mail, but women have hormonal issues at times in their life, right? Meaning that they have changes. So that leads to type 1, so that's postmenopausal. Estrogen deficiency and testosterone deficiency leads to trabecular bone loss. Okay? That's why it's more common. Do men go through menopause? No. Menopause, I coined that term. You can't take that from me. But yes, some men go through menopause, but men do not. So, do not go through type 1, excuse me. So what is type 2? Senile, okay? Do men have senile osteoporosis? Yeah, because men get older. I feel it every day, right? So that's a difference though. It's an altered calcium metabolism and intrinsic problems in bone formations. You guys know the osteoblast and osteoclast, right? So that activity takes a shift in that ratio in the opposite direction than it normally should be. And therefore you have more bone being taken away, right? And not as much bone being laid down. That's what decreases the bone mineral density. Okay? Does that make sense? So secondary as well. Whoops, I almost fell over. Secondary as well. So 65 to 45% ratio, right? Or 65 to 45 ratio. So how does that ratio spread out? Now you become male greater than female, correct? So this is due to other extrinsic causes, okay? There are certain communities in the military that we see osteoporosis, right? And we're like, why is this present? This is a relatively young person, right? Well, there are certain communities that do unlicensed steroid abuse, okay? I don't get into all the craziness about it, but you need to get a good history, because if a patient has a disclosed history of steroid use, right, whether or not it's legal or not, that puts them at risk for this, okay? Also, if they have chronic autoimmune conditions or other systemic conditions, and they've been prescribed corticosteroids. Make sense? Go ahead. Anabolics, illegal steroid use. You can. Yeah, and so you're like, why is that? When you get anabolic steroids, it builds muscle, right? But it tells your body, and you guys haven't had endocrine yet, correct? No, you will. So, but it tells your body to shut off certain signals to create certain things. Okay, so when it tells you to shut those things off, well, guess what happens as a secondary hit? Then other processes get disrupted as well. So that's why we talk about that metabolic dysregulation, essentially, metabolic imbalance, and that's what causes it. Okay, that's your broad answer. When you guys get into endocrine, then you'll get tested on it. Don't worry, you'll know more about it, or you'll get that question wrong. Right? But that's why it says endocrine disorders as well. You see how endocrine disorders and steroid are kind of in the same little parentheses there? So the knee bone is connected to the, right? So when you have certain processes, it's like you guys know the domino effect statement, right? They can kind of tumble and cause other secondary issues. Okay, make sense? Et cetera, et cetera. You see the gaping areas of the bone there? Okay, that's osteoporosis. So, you have time. Clinical symptoms, age greater than 50, sure. Do you have necessarily those endocrine imbalances at a younger age? Not necessarily, unless the patient has a history of early menopause. Right? When you guys get into women's health and other areas, you'll realize that early menopause actually puts patients at risk factors for certain types of cancer. Because some of those estrogen to testosterone, that balance leads to protective components that prevent progression to certain diseases. Right? So the earlier a patient goes through menopause, you can put them at a higher risk for certain types of cancer. Right? Dump that out of your mind. But I'm just trying to get you to understand why it's important to understand, to know these things. Okay? Not recognized until the patient seeks medical attention. So I didn't know I had osteoporosis, doc, but I fell and broke my wrist. I got treated for that. Then I thought I was good, and then I fell and I broke my other wrist. Right? So these patients are at risk for fractures and for certain conditions, and they didn't even know they had osteoporosis. As a country, we're the worst in the world at osteoporosis prevention. We just are. Okay? Maybe not the worst, but we're not good at it. Okay? Because prevention is key. Making sure that you identify and stop the prevention to osteoporosis, because that's a scale, right? You guys know the difference between osteopenia over here and osteoporosis over here, right? And we'll put some numbers to that here soon. Okay? So fractures, spinal hip fractures, very common, especially in senile, right? Deformity, chronic pain, and death following hip fracture. Okay, so I'll tell you this. So what does it mean by deformity? We've all seen, this will be me in a few years, right? The person walking around like this, right, in the grocery store, and you're like, how do they get to that point? Well, if the vertebrae lose that density, do they tend to compress? They do. So that's just one way they do, right? So we'll talk about that in spine as well. Death following hip fracture, there is a certainty that if a patient does not get treatment for a hip fracture, that they will die within a certain amount of time. Right? That is a well-established fact. Okay, so do you think if a little old lady, LOL, right? Little old lady has a hip fracture, do we want to get to that fracture as soon as possible? Yes, because there's a direct correlation with morbidity related to hip fractures. Okay? We'll talk more about that in the other thing. DEXA scan, okay? We all know what a DEXA scan is, right? Okay, I'm going to spend the last few seconds talking about this. You see that scale at the bottom there? Okay? What's the only thing in gold bold? Negative 2.5. All right? I don't want to beat it to death, but I did so last semester, so I'll go again. So we all understand if you have 0 and you go to the right, picture in your mind. You get more positive, right? So if you have a 0 and you go to the left, you get more negative, correct? So osteoporosis on the index that's taken compared to normal populations, right? That bone mass density measurement, if it's negative 2.5, you've now reached the scale where you've gone beyond osteopenia and now you're on osteoporosis. So if it says negative 2.4, is that osteoporosis? Who says yes? No? Okay, good. Because that is correct. So you'd have to be more negative to be more osteoporotic. Make sense? Don't miss that question. It's so easy. All right, but people don't read, right? More negative is more negative. Less negative is less negative. And obviously, if it's positive, you're positive. But in all these, what's normal? Okay, so you don't even have to worry about positive numbers. You're just trying to figure out if you're more negative than negative 2.5. Are we good? Dramatic, I know. So, but it's the best test for monitoring the results of osteoporosis treatment. Do I get into osteoporosis treatment? Not much. Which is to say no, not really. Because does orthopedics treat osteoporosis or do primary care providers treat osteoporosis? What does orthopedic surgery do? We treat those fractures that are secondary to the osteoporosis. Make sense? Okay. But again, it's thrown into my lectures. So prevention, adequate intake of calcium and vitamin D. When are you guys talking about, when you get into clean core next week, I think, and we're talking about these preventative measures, if you've got a person who's above what age? 50, right? And you throw it in there, they're women, right? Especially. Not judging, not characterizing. But if you say that one of your secondary USPSTF recommendations for the patient is to ensure that they have adequate intake of calcium and vitamin D, is that correct? You are 100% correct, okay? Regular weight bearing and exercise? Yes. Avoid alcohol and tobacco, right? I know you guys party on the weekends, that's fine. Right? Decrease fall risk for older patients. So what does that mean? That means that their house looks like some version of, God, what was that word? Something mousetrap. But it looks something like that, right? Where there's all these trip hazards, these carpets that don't have the grip thing on the underneath, right? They're just sliding all over the place, right? Like risky business, right? So you need to make sure that if you have somebody who lives at home by themselves, that they have somebody go to their house and remove all those trip hazards or make their house trip hazard proof, if you will, okay? Because if they fall and break their hip, is there a high chance they're gonna die? Yes, I know that sounds graphic, but if you remember it that way, then I think you won't forget it, right? You should say something like, ma'am or sir, I would like you to have your nephew come over to your house and ensure that you do not have fall risk, because it'll make you more likely to potentially sustain a hip fracture due to the level of osteoporosis that you have present on your DEXA scan. That's how you say it professionally. Don't call them out, don't judge them. Let me judge them. Okay, so intervention. What's the difference between intervention and maintenance? So intervention means that the osteoporosis is present, correct? That you're not trying to prevent it. Pause for effect. I got time. Okay? So make sure when you're reading the clinical vignette, especially on pants, that you understand, are they talking about prevention or are they talking about intervention, which is you can also call treatment, correct? So what do you think they're going to give you? Do you think they're going to give you a negative number in there? Yes. So that again is a level of question where it's taking you to another level of understanding. You understand that the patient is this age, they have this history, their DEXA scan says this, so now they're not in the prevention phase, but they are in the intervention or treatment phase. You see what I'm getting at? So putting those things together, again, second, third, fourth order questions is important, okay? This is what I'll talk about medications, anti-resorptive agents, and anabolic agents. That's the breadth that I talk about in my lecture. You guys are going to get in the farm, okay? All kind of bisphosphonates and all kinds of stuff. It would be unfair of me to discuss it because you haven't discussed that yet at the farm, right? Huh? No? Okay. So I will not test you on it. Okay. Screen your patients. Again, in this country, we suck at it. We're not very good at it. We need to improve at it because is it easier, again, to prevent something or to treat something? In this case, prevention. Okay. What is an osteoporosis specialist? Is that orthopedics? No, that's someone else. Okay, that's somebody that's trained and works with those patients specifically. And do you think they have resources and contracts and agreements with certain companies that will go to a patient's house and do a survey and see if they have fall risks? Yes. Do you think they'll also assess whether or not they need further rehab, specialty support? Yes. Those are those osteoporosis specialists. Okay, that's it. I appreciate your patience and your attention. Have a good day.